Okay, so let's move further. A child fell on his nose and presented later with a nose pain and tremendous general malaise and fever. Think nasal septal abscess. Okay, so what happened? So the child fell on his nose. Okay, so he might have injured his nose and presented later with a nasal pain and tenderness. Now he presented later. If he presented on the same day, so they might have cleaned his injury site, but now there is no cleaning of his injury site, and the clotting has progressed and changed into the abscess. So now, because of the abscess, he is having tenderness and pain and fever and malaise and systemic changes as well. So now you think that, okay, I'm dealing with nasal septal abscess due to nasal hematoma that has been infected. Why? Because he presented later, not on the same day. Now, this is why the nasal septal hematoma needs to be incised and drained in order to prevent bacterial infection and abscess formation on the top of the hematoma. So the answer is not hematoma, as the hematoma does not cause general malaise and fever. Rather, the hematoma has converted into abscess, okay, which has some systemic features. Now, a child who is inattentive at school and it sits close to the TV with bilateral conductive hearing or progressive hearing loss over a 12-month period presented to his GP, and after 3 months he did not show improvement. Okay, so 3 months. Look, otitis media with effusion. Okay, first of all, if a boy presents to you with otitis media with effusion, you should reassure him. Okay, after reassurance, you should tell him that okay, go for 3 months, okay, and just come back for checkup after 3 months. If after 3 months, more than 3 months, he comes to you and he tells you that doctor, uh, I haven't showed improvement. Okay, so now what? Now you should go for the chromat insertion, okay, which is a procedure for otitis media with diffusion more than 3 months. Do we are reassured in 3 months if it is his first visit? After 3 months, you should go for the chromat insertion. Now, when a patient tells you that he is having headache that worsens on bending the head forward in the early morning without nausea and vomiting, so the patient will tell you that whenever he bend his head, okay, it seems like his head is falling down on the ground. Okay, his head is falling down on the ground. So and headache worsens. Okay, so there's the hint that you are dealing with sinus headache or chronic sinusitis. Okay, so that you are dealing with chronic sinusitis. Okay, so let's move further then. One thing more I want to tell you, what is acute versus chronic sinusitis. Okay, so acute sinusitis is less than 12 weeks. If a patient has sinusitis that is less than 12 weeks, this is more of a acute symptoms. Okay, and this will be often uh, followed by a common cold. Patient will tell you that he had a common cold. After that, he developed a headache, and the duration is less than 12 weeks. So you probably are dealing with acute sinusitis. And if a patient tells you that the symptoms are longer than 12 weeks, so there you know that you are dealing with chronic sinusitis. Okay. Now, what will be the symptoms? The symptoms will be nasal congestion. Okay, his nose will be blocked. Okay, or congested, and there will be nasal discharge. He will tell you that he is having some discharge from the nose. And the next thing is, because here is the face, here are the eyes, here is the frontal sinuses, okay, and here is the maxillary sinus, okay, here is the nose. So maxillary sinus, frontal sinus, and here will be ethmoid sinuses. So these basically what happened is whatever, because they are secreting their fluids from their sinuses into the nasal cavity. By any means or by any chance, if you block the septum here, or if you block the pathway from where they were supposed to secrete their secretion, if you block it, so here will be congestion of the secretion. So the secretions will be blocked and they will get infected. So you will get sinusitis. Okay. Now, if the sinusitis is more than 12 weeks, this is called as chronic. If it is less than 12 weeks, it is called acute. Okay. And what will be the symptoms? The symptoms will be nasal congestion, nasal discharge, and facial pain. Now, because here is infection going on and the secretion cannot get rid from the sinuses because there is blockage of the sinus cavity. So there will be facial pain and pressures and sometimes described as headache. Okay, sometimes mostly the frontal sinuses, when they get infected, they will get sinuses, frontal sinus headache. Okay, and there will be a reduced sense of smell. Okay, there will be reduced sense of smell. Okay, that was it. Now, one thing more I want to tell you is, what is the management of acute sinusitis? Acute sinusitis. Okay, this is very important. Okay, now acute sinusitis, you should remember that I told you that the symptoms will be less than 12 weeks. Okay, less than 12 weeks. Now this is for sure. Okay, now acute sinusitis are divided into two types, two things. Okay, here I have got some space. So now acute sinusitis are divided into two categories. One is when symptoms are less than 10 days. When symptoms are less than 10 days, and one is when the symptoms are more than 10 days. Okay. When symptoms are less than 10 days and he is feeling sick or he is having some severe pain, so you will give him, or you will provide him with paracetamol or ibuprofen for pain. Okay. Now, the next thing is you will recommend some nasal saline, okay, nasal saline, which will relieve the congestion. Okay, which will relieve the congestion. Now, and you will also provide with some nasal decongestion. Okay. But remember one thing: these may or may not be prescribed, may or may not. Okay, but this thing is for sure. But if the patient presents you with the symptoms which are more than 10 days, now you will give him nasal steroids. Nasal steroids. Okay. For how many days? For 14 days. You will give him nasal steroids for 14 days. And if it is a viral, okay, because most of the time sinusitis are viral origin. Okay, but still, if if the patient seem to have some bacterial secondary infections, okay, bacterial infections, then you will give him some antibiotics as well. Okay, and for 7 days. Okay, so the antibiotic prescription is reasonable, and you should advise him to use it if only symptoms rapidly worsen or if did not improve for 7 days. Okay, so if he is getting his condition worsened, so then you can prescribe him with antibiotics. Now, okay, I hope you people understood. So there will be no recommendation of oral decongestion, antihistamine, mucolytics, steam inhalation, or to the patient who is having acute sinusitis, which is less than 10 days. Okay, and no antibiotics are required at this stage, but you should give him when his condition worsen and it is more than 10 years for 10 days. Okay, now that's it, I guess. Now, how will you treat chronic sinusitis? Chronic sinusitis. For chronic sinusitis, you have to give nasal irrigation Nasal irrigation with what? With nasal saline. Nasal saline, that will lead to decreased congestion in the nose. And the next thing you want to go do is intranasal corticosteroids. You should give him steroids for 3 months. Okay, you will give steroids for 3 months for the chronic sinusitis. This is the management of chronic sinusitis. Now let's read it out. If there is sinus headache due to chronic sinusitis, both sinus headache and migraine worsen when bending the head forward. However, migraine is more intense and tends to be associated with other symptoms like nausea, vomiting, and photosensitivity. Weak or altered voice in some occupation where there is voice overuse. Teacher, actor, singer, commentator. Okay. Now think of functional dysphonia. What is functional dysphonia? Okay. When the voice is disturbance in any absence of any structural abnormality of do not be tricked by the history of the previous respiratory infections. If the weakness of the voice occurs during the respiratory infection, the cause may be laryngitis. Okay, let's move further to presbycusis. Presbycusis is the inability to hear high frequency sound, that is, raising the voice would not improve hearing. Affects the elderly patient, bilateral sensory neural hearing loss. So this is basically the normal disability of the elderly patient. So when they get older and older, so they get the disease which is called as presbycusis. There will be bilateral sensory neural hearing loss. So there will be difficult to understand the speech and follow conversation. The patients usually do not recognize they have the hearing loss, don't shout, I'm not deaf, because they don't recognize themselves as they are having sensory neural hearing loss. Thus, usually presented to a clinic by their family. There will be poor handling, especially in the noisy environment. Bilateral digital hearing aids. So you will prescribe him with digital hearing aids. Okay, they will increase the high frequency sounds. Okay, so autosclerosis, there will be conductive hearing loss, inability to hear low frequency sound, therefore raising the speaker voice would allow the patient to hear better. Why? Because I told you that this is a middle ear and this is the outer ear. So basically the stapes is having some problem and there is proliferation of some bony material around the stapes. So which will let him to decrease the sensation. It won't be able to convey his vibration through the membrane because of the osteocytes developing around him. Now there will be inability to know the low frequency sound, but when he is exposed to the high sounds so that he can hear properly. Raising the speaker voice would allow the patients to hear properly. So there is the difference between them. So it also affects the people at the younger age, 15 to 45, because it is from genetic, I told you, and from the measles the patient can get, or pregnancy the patient can get. Another important point is that the patient with autosclerosis usually hear better while they are in noisy environment. Now, epistaxis. What is epistaxis? Initially, what you will do is lean forward and pinch the cartilaginous soft part of the nose for 10 to 15 minutes. Okay, first of all, you should pinch for 10 to 15 minutes. And the next thing is, if the patient is having recurrent episodes of the epistaxis and there is visible blood vessel in inferior, and if there is still active bleeding, okay, what you should do is anterior nasal packing. This is the treatment for active epistaxis. But if the patient is having recurrent episodes of epistaxis, then you should look for the blood vessel, which will be visible in the littles area, and inferior part is this part. Okay, this part is called as littles area. It has many blood vessels. So what you will do is you will do the nasal cautery at one side first, and then you will do the nasal cautery on the other side on next day. Why won't you do both nasal cautery on the both side at once, because you might lead to the nasal perforation, because nasal cautery is actually the burning of vessels. Now, nasal cautery at one side of the symptom initially, no other value would be if no active bleeding is present, then topical. So the first procedure was nasal cautery. Okay, the second procedure could be you could apply some topical substances for recurrent epistaxis. Okay, remember that there is no active bleeding going on right now. Okay, because if there is active bleeding going on right now, and you apply silver nitrate here, silver nitrate, because of the ongoing bleeding, your silver nitrate could be washed off. So you should not risk the silver nitrate here to be washed off. Rather, you should wait for it to stop bleeding. And when it is stopped, then you should do nasal cautery first. If not available or you are not doing, then you could try topical chlorhexidine and neomycin cream. Okay. As the bleeding is bilateral, so both sides will eventually need cautery. However, we cannot do cautery on both sides at the same time because of the septal perforation. Now, cautery with silver nitrate should be avoided if there is active bleeding. The silver nitrate would be washed out if there is active bleeding. Recurrent episodes of epistaxis plus visible blood vessels are seen on the anterior and inferior part of the nasal septum bilaterally. There is still active bleeding at the time of perforation. Look, in active bleeding, what you should do first is pinch, and the other thing is nasal packing bilateral. Now, cautery with silver nitrate should be avoided if there is active bleeding. Why? Because you can wash it off. Okay. So the anterior nasal packing is left for 2 days. Now, acute tonsillitis, painful sore throat for 2 days, ear pain, tonsils are reddened. Okay. And what should you look for? It is a central criteria. Central criteria is a criteria. It has 4 objectives. Okay. So whenever you fulfill 3 objectives out of 4, you should prescribe antibiotics. Now, what are the 4 criteria? First is the fever when more than 38, tender, enlarged anterior cervical lymph nodes. And when there is tonsillar exudative pus or there is no associated cough, it means it is not lower respiratory tract infection. It is rather acute tonsillitis or upper respiratory tract infection. So if 3 of these are present, then you should go for antibiotics. What are the antibiotics? That are phenoxymethylpenicillin. Okay, when fever is more than 38 and there will be tender means pain on touch, enlarged cervical lymph nodes, and tonsillar exudates. Exudates are the pus which are collected in the tonsils. In bacterial otitis media and accessory, in bacterial tonsillitis, phenoxymethylin or penicillin. Now, oral steroids can weaken the immunity and causes candidiasis. Okay, and one of the possible candidiasis site is laryngeal candidiasis when the patient present with hoarseness of voice. Okay, so laryngeal candidiasis could be secondary to steroid intake. Okay, why? When the patient is asthma patient, he is constantly or continuously having steroid therapy. So he might present to you with the hoarseness of voice. This hoarseness of voice is basically laryngeal candidiasis. Okay, because of the steroid taking secondary to asthma. Now, what is benign carotid tumor? It is the most common type of benign pleomorphic adenoma or mixed tumor. It is asymptomatic, solitary, painless, firm. These are all the conditions of the tumors, like solitary, painless, firm, mobile mass swelling at the angle of the mandible that grows slowly. Now, what you will do is you will do superficial periodictomy. Why? Because there are certain lobes of the carotid gland. In the superficial, mostly the tumors are located. So you will remove the superficial periodictomy or enucleation. There is 2 to 10% of the risk of malignant transformation. Important diagnoses are carotid enlargement, Sjogren's syndrome. Okay, so Sjogren's syndrome is an autoimmune disorder where your whole body gets dry. Okay, like characterized by carotid enlargement. You will get xerostomia, like dry mouth, or keratoconjunctivitis sicca, like dry eyes. Okay, so basically your mouth will get dry, your eyes will get dry, and it is an autoimmune disorder. Okay, and your carotid glands will enlarge. 90% of the occurs in the females. Second most common connective tissue disorder. Okay, and bilateral non-tender enlargement of the gland is visual. So you will get to see both. Okay, but here in the benign parotid gland, mostly it is solitary. So treatment is supportive in Sjogren disease. Now there is an increased risk of the subsequent lymphoma and mumps. What is mumps? Mumps is caused by RNA paramyxovirus and tends to occur in winter and springs. Okay, so the most important thing is it spreads by the droplets. Droplets excreted by an infected person. Okay, when these droplets are in contact with other person. Okay, so you will get this disease, the RNA paramyxovirus. Paramyxovirus. It happens in winters and springs. So in respiratory tract and epithelial cells, parotid glands, other tissues, okay, they can get into these areas like respiratory tract, epithelial cell, or parotid glands. Now, infective 7 days before and 9 days after. Infectivity period is 7 days before and 9 days after the parotid swelling starts. Okay, so you are getting parotid swelling. So 9 days, 7 days before and after 9 days after swelling ends or swelling starts. Incubation period is 14 to 21. What is the clinical feature? Fever, malaise, muscular pain, parotitis, air pain, or pain on eating. Okay, whenever a person try to eat, okay, because of the parotid gland and the submandibular or the movement of the temporomandibular joint, because of the inflammation of the parotid gland, there will be some air ache or pain on eating. Unilateral initially and then becomes bilateral in 70%. Okay, so it is bilateral. Now, how can you prevent it? Measles, mumps, rubella. You have to give him measles, mumps, rubella vaccine. Okay. Now, management will be rest. There is no management actually. Just to give him rest on paracetamol for high, and this is notifiable disease. The complication will be orchitis, which is very important, uncommon in prepubertal males, and but occurred in the around. So prepubertal is when they are very of 7 8. Prepubertal means that they are near to puberty. Okay, so uncommon in prepubertal males, but occurs in 25 to 35 patients. In post-pubertal males, okay, so they are common in post-pubertal who have reached puberty. Typically occurs 4 to 5 days after the start of parotitis. Hearing loss will be there, usually unilateral and transient. Okay, there will be unilateral and transient. These are some complications: meningoencephalitis, meningitis. Other differential diagnosis will be parotitis, will be painful, tender, mandibular or tonsillar cancer, not mobile. Okay, so these are the differential causes. So if the parotid gland gets infection, so you will have painful, tender parotid gland. If mandible gets the infection or mandible is involved, or there could be tonsillar cancer, but those are not mobile. Sjogren's syndrome there should be associated with the dry eyes and mouth. The initial step for epistaxis is lean forward, open mouth, pinch the nose, okay, 10 to 15 minutes, and then you should send him for it's an emergency to perform anterior nasal packing. Okay. Now, what is devenous vertigo, which lasts for seconds? This is BPV. History of the viral upper respiratory vestibular neuritis and history of the viral upper respiratory infection, hearing loss, tinnitus, labyrinthitis. Another summary: vertigo, history of the common cold, vestibular neuritis. Okay, this I already explained. Okay, okay. The next one is So what is noise-induced hearing loss? It is the most common, second most common form of sensory neural hearing loss after the presbycusis, which is age-related to hearing loss. It occurs due to exposure to a sound, loud sound. It can occur due to occupation, noise, working in a shipyard, army factories, occupational hearing loss. The form of this type is bilateral sensory neural hearing loss. Bilateral sensory neural, the patient cannot hear well in a large room when a number of people are talking simultaneously. He cannot understand the speech while on the phone. He feels the sound is muffled. Okay. So presbycusis occurs in older patient. Okay. But this is the most common, second most common. It can occur due to occupation because most of the people who are working in shipyard, there is a lot of noise, or army or factories, there is a lot of noise. So because of that occupation, they can get the bilateral sensory neural hearing loss. Okay. So let's take a break.